Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your co-host, Dr. Ogul Uner, and my guest today is someone I look up to in ophthalmology and life, Dr. Sila Bal. Dr. Bal is a cataract and cornea surgeon at Straub Medical Center in Honolulu, Hawaii, and the original host of the Pupil Pod. I've been fortunate to know Dr. Bal for over 10 years now when we met in a global health class at Penn. You may have seen her funny and informative posts on Instagram and TikTok as Dr. Eyeball. She's also a fierce advocate for global health and sustainability in ophthalmology. Dr. Bal, thank you for joining me tonight and giving me the opportunity to co-host the Pupil Pod.
Oh, what can I say? This is such a full circle moment for me. You guys can't see me because this is an audio only podcast, but I'm over here cheering and smiling and air clapping for I look up to you. I can genuinely say that I look up to you. You're one of the most hardworking, sweetest, most caring, funniest people that I am honored to know. So I'm really just so excited for you to take this podcast and make it your own. I can't wait to listen to the episodes, and I can't wait for this episode. It's my first time as a guest on my podcast.
Oh, you're the best. Thank you so much for everything that you've brought to the Pupil Pod, and I'm very excited to present this case for our listeners. Now, moving on to the case, we have a 55-year-old woman with a history of left foot cellulitis who presented to the emergency room with a day of rash with eye and sore throat. Workup revealed recent treatment with ibuprofen and doxycycline for her left foot cellulitis. Dermatology and ophthalmology were consulted due to concern for Stevens-Johnson syndrome, or SJS. Before we get into the case, can you review with us what exactly is SJS?
Yeah, that's a really great question. And as ophthalmologists, we will definitely get a consult like this at some point during our training. And then if you're like me and you're a cornea specialist and you work for a hospital, you're probably going to see a lot of this. So SJS is really a hypersensitivity reaction to some sort of insulting agent. So there are infectious causes. Usually it's like HSV, strep, or adenovirus, or more commonly, and what we're going to see the most of is some sort of offending drug. So our main culprits here are sulfonamides, anticonvulsants, and then the scariest, right? Because we all take these all the time, are NSAIDs. So you could have taken NSAIDs before, and then just for some reason, you have this hypersensitivity reaction to NSAIDs this one time. Now, when you have the hypersensitivity reaction, it usually involves the conjunctiva and the oropharynx. So those are the two areas that we see this most commonly when it is still classified as SJS. And we'll talk a little bit more about the classifications in a little bit. I'm not going to pretend I'm some sort of pathologist or immunologist and go into the pathogenesis of this, because truly I am so far from qualified from doing that. But the pathogenesis is complex, and it's most likely mediated by cytotoxic T cells that result in apoptosis of keratinocytes. So it makes sense with what we see on exam, right? So you're having apoptosis of those external cells.
I think it's such a scary disease, as you mentioned, and something that we will all see, as you said, in hospitals, and unfortunately carries a very high mortality that we'll talk about more. And speaking of the classification, what is the difference between SJS and TEN, or toxic epidermal necrolysis? We tend to hear those two often together.
Yes. Sometimes you'll hear them in the same overlap syndrome. And I think, at least for me as an ophthalmologist, and I'm sure there are more nuances to this if you're someone who studies this for a living, or if you're a dermatologist, maybe even, but for us in ophthalmology, we kind of categorize this based on the percent of the body surface area that's involved. So if it is limited to less than 10%, then we're talking about SJS. So these are our patients that come in that have severe oropharynx involvement. They probably have involvement of the ocular mucosa. Those patients are generally going to be SJS. Now, if it is somewhere between 10 and 30% ocular involvement, that's where we get into that gray area, right? It's this SJS-TEN overlap syndrome. So we can argue about the nuances all we want, but just kind of remember those numbers, 10 to 30%. And then anything over 30% of body surface area, that's really toxic epidermal necrolysis. That's going to involve a lot of higher order care, and it's going to have a much higher mortality and morbidity associated with it.
That's great. So 10% and 30% are our cutoffs. And how do these patients usually present?
These patients can be really tough because they come in with very non-specific generalized symptoms early on. So they'll have things like fever, malaise. They'll even have URI symptoms. So they'll say like, "Oh, I have a sore throat, maybe I'm a little bit congested." But the key thing here is that all of that comes on kind of suddenly, and then they develop these skin eruptions, usually within a few days of those non-specific symptoms. There's a classic finding, and it's a target like lesion with a red center surrounded by a pale ring and then another red ring. Now, I will say I haven't seen that classic finding, but that's probably because I zero in on the eyes as soon as I'm consulted on these patients. I'm not even thinking about the rest of their skin, but that is something to just keep in mind. There is this like classic skin eruption that we think about. The primary ocular findings, especially early on, are going to be just a generalized conjunctivitis, maybe some episcleritis. So the eyes are going to be a little injected. You might not see any staining or anything like that. It might just seem like conjunctivitis at first.
And I think that's why it's so important for us to be involved so early, because these patients can really decompensate quickly, like we'll talk about, and that the signs and symptoms can be so nonspecific. And so, speaking of staining and other findings, what are some important examination findings that we should evaluate in every patient with concern for SJS?
So I always tell my residents and my trainees to start with the basics, right? Just because you're consulted about an SJS patient doesn't mean that you skip vision, pupils, and pressure. You definitely want those three valuable pieces of information. Number one, because you want a baseline. You want to know, is the pressure already elevated before you start putting a ton of steroids on that eye? And you want to know what their baseline vision is so that you can kind of track, is it getting better or worse over time? And then beyond that, the most important findings are, is there staining? And you need to look at the conjunctiva, both bulbar and palpebral conjunctiva. You need to look very carefully at the cornea. And then you need to evaluate the fornices because you can start to see scarring and symblepharon formation earlier than you would think. So it's not going to be day one, patient comes in with a symblepharon. But if you start to see membranes, then that's a sign that that eye is very hot and very inflamed and that there could be symblepharon formation pretty quickly.
That's such a good point. And so, okay, circling back to our patient, you performed a complete exam and you noted a 2+ bulbar conjunctival injection, but no areas of staining. How would you treat this patient?
Yeah, so this, hopefully, if you work with a hospital that's good at getting in touch with the ophthalmology team, is probably where you're first going to start out with these patients. They just came in, they got diagnosed, and they have this like conjunctivitis or this conjunctival injection. At this point, where there are no epithelial defects, you still treat the patient with steroids. Now, I think that's very important to understand. I also personally add antibiotic prophylaxis. That's because the algorithms that I work with, the guidelines that we work with, say that it is important to have the antibiotics to prevent any superimposed infection moving forward should the epithelium start to break down as the disease progresses. The current standard of care is to start topical prednisolone 3 times a day, Lotamax or loteprednol ointment to the eyelids also 3 times a day, and then just throw moxifloxacin, fluoroquinolone, or some other light antibiotic on there. Try not to use any sulfonamide antibiotics since we already talked about those being offenders. 3 times a day as well, even with no epi defect. I also start artificial tears on these patients all the time. So if they have preservative free tears available as an inpatient, then you can do them every hour. If they don't, try to push them to get preservative free tears. But if they still won't, then the next best option is to just use regular artificial tears, but really just use them 4 times a day. The most important thing to distinguish is that these patients are going to have their acute phase. So, you monitoring them closely every 1 to 2 days to see whether they progress. And then later, we're going to talk a little bit about what we do in the chronic phases of disease.
I think that sounds like a great plan initially, because the importance of controlling the inflammation is paramount. So I just wanted to emphasize that making sure that we treat these patients even if we don't have the defects, I think is so important, like you mentioned. And so on follow-up examination 2 days later, We do note an epithelial defect on both corneas, diffuse staining of the palpebral conjunctiva, and a new membrane that's forming in the left eye. How would you progress your treatment in this case?
This is a classic SJS case, right? You see them, they're okay, and then they start to decompensate over a couple days. We always use the steroids, even with an epithelial defect, because you need to address the root cause, right? The root cause is this inflammatory state. So you need the steroids. At this point, you're going to need more frequent topical steroids and you're going to need amniotic membrane. So there's a way to think about, do I do a BCL? Do I do Procara? Do I do an amniotic membrane graft? And the best way to think about this is what part of the eye is affected, right? If you see this patient and the conjunctiva looks fine, so it's injected, but there is zero staining of both bulbar and palpebral conj, you can probably get away with just placing a BCL over a large epidefect over the cornea. Personally, at that point, I would still probably favor a Procara, but the guidelines say that a BCL would be okay. If you're noticing any staining of the bulbar conjunctiva, that right away buys you the Procara. It's time to put the Procara in. Most often, though, you're going to start to see staining of the palpebral conj. When you start to see staining of the palpebral conj, that patient needs an amniotic membrane graft. You need to cover the entire conjunctiva, so under and around both upper and lower eyelids. So for those of you that haven't done an amniotic membrane graft yet, there are lots of different ways to do this. I will tell you the way that I was kind of taught to do it. It's a really quick and I think relatively easy. I mean, I'm air quoting easy here because like it is not easy. And the reason it's not easy is because these patients are really sick. They're either in the ICU or they're admitted. Their oropharynx is just like oozing blood. They're really in pain both in their eyes and in their mouth. And so you can try to do this bedside. I have done this bedside many times. Generally, what I'll do is I'll call ahead to the team. I'll ask them to give the patient some sort of pain management and anxiolytic if they can. But if your hospital is willing and able to get you into the OR, it's just so much more comfortable if you can semi-sedate these patients to do this. And then what you really need is you need your amniotic membrane. It comes in these 10 by 10 sheets that you can get. So 2 of the 10 by 10 sheets. You need cyanoacrylate glue. I like to have 6-0 Vicryl or 8-0 Vicryl, whatever you have available, sutures. And then you also just need IV tubing. I take the IV tubing, so just like regular run of the mill IV tubing. I take the IV tubing and then I just try to kind of guesstimate how far of a tube I would need around the fornices of each eye. So you guys can't see me, but I'm holding up OK signs around my eye and just holding them up to my eyes. But that's kind of what I do with the IV tubing. So I just make like a round ring, and that's going to be your symblepharon ring. So I estimate how big that ring will be. Oftentimes, you'll need to make it a little bit smaller than what you predict because it won't fit all the way into the fornices. But better to start large and just snip it off at a little bit at a time to get it to fit than to start too small because you don't want it moving around a lot. You really want it to sit snug in the fornices. And then what you do is you cut that IV tubing at the length that you determined. One end will just be a flat cut, so just a normal flat cut. The second end is going to be a super beveled end. So really bevel it at as much of an angle as you can. And then this is my little trick. I like to take my Westcott scissors, stick them in the flat cut end, and just open them a little bit so that it increases the diameter of the tubing on that side so that it's easier for you to slide the beveled end into that cut end. And there you go. You have your symblepharon ring. So that's all set. Now comes the fun part. You're taking your amnion. There is a lot of debate, epi up, epi down. I like epi down. Doesn't matter. You can do epi up. I don't think that there's any real evidence one way or the other. And then you're going to take cyanoacrylate glue. You're putting it along. Oh, sorry. Let me backtrack. Before you do your cyanoacrylate glue, cut the lashes. So just take your Westcotts, go across the lash line, cut the lashes, get those lashes out of there. You want it to be nice and flat so that the amnion sits nicely. Then you take your cyanoacrylate glue, you put it on the upper eyelid, like right over the tarsus, And then you take your amnion, you put it over the cyanoacrylate glue. You take either Weck cells or like whatever you can, a cotton tip applicator. You snug push the amniotic membrane into the upper fornix. Then you take your symblepharon ring and you put that in and push the amniotic membrane with your symblepharon ring into the upper fornix. And then you do the same thing for the lower fornix. You just use the symblepharon ring at this point. You just finagle, move it around, shimmy it side to side until you get it in. And then again, cyanoacrylate glue on the bottom lid where you cut the lashes and glue it down. Now, you can leave it with just glue. I like to just put two anchoring sutures in the upper corners just to give me peace of mind, because if it starts to pull off, it's going to be a real project to try to put it back bedside, and especially to put sutures bedside. So you can do the 80 vicryl sutures, or you can do nylon if you feel like you can remove the sutures, depending on how compliant the patient is or how much pain they're in. Some patients are in a lot of pain and really can't tolerate anything. So any of those are fine. Those sutures are really just anchoring sutures to keep it there. So that sounds a lot more straightforward than it ends up being. So at this point, I just want to tell the residents, if you're doing this and it feels really hard and you're really stressed, that is normal. The first time I did it, I remember it was like really chaotic because a lot of moving parts, the patients are in a lot of pain, their eyes are really tender. So just do your best, get that amniotic membrane in, make sure it's covering as much of the eye as possible, and you are going to help that patient tremendously.
I'm so grateful that you have touched not only on the detailed steps, but to really care for the patient and their pain. Because I remember when I did this for the first time, it was really chaotic, like you mentioned, and the pain is certainly something to really keep in mind. Symblepharon rings in general are not really comfortable with patients. Patients with procara, if they don't have significant neurotrophic disease, they feel it. So it definitely is a lot to work with, but there's so much gain at the end. So thank you for going through that detailed list of steps. So at what point do you remove the symblepharon rings?
It's a great question. Well, first of all, the pain thing, yes, absolutely. I mean, these patients are just so uncomfortable, and you really have to understand that going in to make both your job easier as their doctor, and then their life easier in a period of their life where they're deeply suffering, right? Um, it ties into the removal of the ring because number one, every time you see these patients, every day that you check on them, they are going to ask you, when does this ring come out? That is going to be their number one question. Hello, I don't care. When does this ring come out? That's going to be the conversation that you have with them. And then number two, a lot of people I know like to kind of rotate the ring a little bit. So like every few days, try to rotate the ring. Do your best with that. I've had patients that will not, absolutely will not allow me to touch their eye. That's fine. And then I have patients that are like, sure, you can rotate it even though it hurts. Do your best. Usually I try to get the ring out at around 1 week to 10 days once that AMT has completely melted away. So if there's still amnion there, then you can keep it in. But otherwise, once it's gone, you can kind of take the rings out. You don't want to take them out sooner than 1 week because a lot of active inflammation is still going on and symblephara can still form. So you really want to keep those rings in there to try to prevent that scarring from forming. But about 1 week to 10 days is usually a good time to have that conversation, and then you can decide if you need to replace them.
Great. So you follow up with the patient and remove the symblepharon rings. She now has significant improvement in her ocular and oral symptoms. The only finding now are dense central PEs. What do you expect in the long-term management of this patient?
Yeah, so this is the thing that as residents, I don't think that we fully appreciate, right? Because you see these patients when they're acutely ill, and then like maybe sometimes you'll see them in attending clinic, but you're not following them long term. And that's something that I didn't realize. And now when it's me and I'm no longer the trainee and these are my patients that I see long term, I realize just how much of a chronic disease this is for patients. So I always have that conversation with them. I let them know we're through the worst part of the disease, but now we have to stay on top of it to make sure that your eyes are healthy for decades to come. And the way that we do that is through frequent lubrication and then adjusting our management based on the symptoms that they're having. So, this is a very destructive disease. eyelid destruction can lead to meibomian gland dysfunction. They can have symblepharon formation. They can have very, very severe dry eye. So you want to just tailor the treatment to whatever it is that you're seeing in their eye. Other things that you commonly can see are persistent epithelial defects, limbal stem cell disease, entropion, trichiasis. So these are all important to monitor, and these patients are the ones that you want to follow closely. So generally, I'll start them out with lubrication, very slowly wean them off their steroids, and then I'll put punctal plugs in everybody just to make sure that their eyes are optimized. And from there, I'll follow them. Now, here in my short career so far, I've been very fortunate, knock on wood, that all of my patients have recovered pretty robustly. They do have very bad ocular surface disease, but it's not like they have like cicatrization or like any type of keratinization of their cornea. However, in severe cases, and I have seen a lot of these at Mass Eye and Ear, you need to discuss and manage visual rehab for these patients. So obviously keratoplasty is out. Okay, these grafts will fail. There is no way that you can do a PK for these patients. It will fail immediately because of the ocular surface. Type 1 K-pros will honestly also fail. So if they have very, very severe disease, then your real only shot at giving them any type of visual recovery is going to be a type 2 K-pro. And as you can imagine, that's a really big surgery, and that's a conversation that you need to have with the patients. They should really be at a tertiary care center for that. That's not something that you want to take lightly. If it's just ocular surface that they're just suffering from symptoms, another really important treatment is the PROS lens. These scleral lenses, the PROS lens technology is incredible. Patients love it. So that's something to keep in your back pocket for those patients.
Yeah, so many options, yet also a lot of failure associated with some of these options. So, thinking about what we've talked about with lenses and surgery, how would you counsel this particular patient?
So fortunately, this patient is doing well once we remove the AMT and the symblepharon rings. So I always tell my patients, we are a team when it comes to your eye care. I want you to have the best possible outcome. And in order to do that, I give you recommendations and coaching, and I expect you to try to take those recommendations and do the best that you can to take care of your eyes. And I know it can be really scary to hear that you're going to have to chronically take care of your eyes, but this is something that will give you the best chance at the clearest vision possible for the longest time possible. So while this is a chronic condition, we're going to work together to make sure your eyes stay healthy. And in this case, that would involve very frequent preservative-free artificial tears, seeing me every 1 to 2 months, at least in the beginning, until I know that they're definitely stable, and just making sure that if anything comes up at all, eye redness, eye pain, blurry vision, that they call us right away and get in to see us right away.
I love the team mindset that you put forward. I think that's so important for these patients and other patients who we follow for a very long period of time, especially when we follow them so closely in the first few months. So that was great. So I know before we close that you always wrapped up your episodes by asking a question to your guests. Since many of our listeners are trainees, I would like to ask you if you could go back in time and give your younger self one piece of advice, what would it be?
Thank you, Ol. I love that you have your own question for this. This is really beautiful. It's a really tough and interesting question, especially for me, because the first thing that comes to mind is totally not academic at all. Because as many of you that might have been following me know, I lost my mom right before I graduated medical school. So my biggest, like, what I wish I could have told my younger self was to just really understand that life is so short and so not guaranteed, and to hug the people you want to hug and show them the love you want to show them, and really just prioritize your people. And then for my younger self academically, I think I would just tell myself, like, it's not that serious. And it seems so funny because the people that know me know that it was that serious. But I would just tell myself, it's not that serious. You're going to learn, focus on a few things per day, and it's all going to work out, and you're going to come out of this alive. Because sometimes I would just be so worried about the amount of information and the amount of things that I had to do. But if you really just try to focus on a few things at a time rather than everything all at once, I promise it comes together.
I love both of your answers, and I think a non academic answer is totally okay. We are one person, but we have multiple different facets. And I really liked how you emphasized keeping your community close and making sure that you appreciate them on a day to day basis. And I really enjoyed your advice for your academic younger self, too. So lots to learn from, and I'm always inspired by you. So thank you so much for those answers. And Dr. Ball, thank you for joining us on this episode of the Pupil Pod.
Oh, I'm so excited for you. I'm so excited for the listeners to get this fresh perspective. You're probably going to take this off a million times better than it's been. So I'm just super, super excited for you. And I'm just so honored to have watched you throughout your growth process.
Oh, you're the best. You've been the best mentor, best friend, and I'm super excited to work with you and the whole team on the Pupil Pod. So thank you. Thank you for those tuning in, and see you next time on the Pupil Pod.